And so Dr. Hussein is an infectious disease expert who is joining us and who will be speaking to us, of course, about infectious disease pearls. So Dr. Hussein, I will turn it over to you.
Thanks. Are you all seeing the presenter slide or the main slide?
Oh, we are seeing the presenter view. I'm sorry.
Okay.
So if you want to
No.
switch.
Perfect. That
Perfect.
better?
Yes.
Yes. Awesome. Hi, everybody. Thank you for having me. I know you've had 3 days of lectures and long things, so I will try to make this as entertaining as possible, as well as hopefully informational. So as mentioned, my name is Abby. I'm one of the clinical assistant professors here. I work predominantly at Montlake. And we're going to be talking about general infectious disease stuff today. No real big disclosures. I'm still not cool or fancy enough to have those. And I think one thing I want to highlight is that ID is a huge range of topics. And so when we're talking about being tested on the boards about this type of information, it makes up about maybe 9% of the overall exam. But if you go to the website and you kind of look at the individual topics, they'll show you like quite a few. So there's only going to be probably 21 questions or so. But the range of topics is pretty massive. And all of these sections are going to be tested by like less than 2%. So all of this is to say we're going to cover a lot of stuff today. You'll have the slides obviously for review. We may not get through all the info, hopefully through all the cases, but there's some extra slides on the end that are just some pearls for you all to kind of review later as needed. But just don't let this overwhelm you. Most of this everybody already knows and sees, so we're just going to try to focus on some high yield points here. So typically when we're thinking about being tested on ID stuff, for cases that are trying to get you to talk about organisms that may not be a common thing that you see, the question is most often going to be kind of first here. So just asking, what is the diagnosis? What is the organism that we're thinking about here? For infections that are a little bit more common, you're probably going to get more of those second order questions. So what diagnostic tests? Is there an association that we should be looking for? Maybe management questions. And so that's typically how we should be thinking about those things. For HIV, which is in itself an entire topic, oftentimes they're not really focusing on management here, but more so diagnosis of opportunistic infections, clinical presentations, things like that. So just to kind of get us started. So let's just jump into some cases and, let's see what we got. So first case today, we're going to talk about a 66-year-old who presents with this new seizure, some upper extremity weakness. Husband reports some decline in performance over the past month. History is really notable just for Crohn's and some peptic ulcer disease. She's on natalizumab, some amlodipine, and a PPI. And so she comes in, gets a bunch of labs that are normal, has negative HIV. Her physical exam is notable for some ataxia and some cranial nerve palsy. And then you get this MRI that shows no mass effect or anything like that, but just some multifocal areas of demyelination. So what comes to your mind when you kind of put these things together? Oh, and I should ask, do we have, oh yeah, it's right there. I was like, where's the poll? It's on my other screen. Okay. I'm getting some answers here. Good mixture. Okay. Well, it's pretty good. Okay. Oops, did I press the button? I don't know why I touched it. Sorry. Okay. So some spread here a little bit. A lot of people thinking about E, so HSV encephalitis, which I love that that's on people's minds because people didn't think about it a lot before. But then some other spread here. Some people thinking about JC virus, CMV. Awesome. So all great things. So the answer here that we're looking for is going to be JC virus. So JC virus is named after John Cunningham, not JC Chazet from NSYNC, but it's a good way to remember. So when folks are talking about demyelination, what they're really trying to get you to think about is progressive multifocal leukoencephalopathy, which is a mouthful, but PML for short. So this is caused by JC virus, which is typically a reactivation. JC virus alone can kind of hang out. Nobody would know it exists. But then when you get reactivation, typically associated with some type of hematological malignancy, untreated HIV, these are the things that you could consider seeing. One of the big signs in this stem is that they mention natalizumab, which has a black box warning for JC virus reactivation. And so something to think about. So in folks who may be on a biologic or who have other reasons, this is something that could pop up. Imaging usually just shows some multifocal white matter. If we were thinking about HSV encephalitis, for example, which was a popular choice, our MRI will often show us some temporal lobe um, signs there. And then often the stem will maybe mention a history of HSV or an unknown history of HSV. So things to look for there. When we think about diagnosis for this, we often check for a CSF, no antibody, but a PCR specifically. And sometimes that might come back negative, so definitive diagnosis would be requiring a biopsy. And the treatment here really is to either reduce immunosuppression or optimize antiretrovirals if this is someone who has untreated HIV. So main points here is that consider PML, which is caused by JC virus for folks who have any MS-like symptoms or who are on any immunosuppression. The next case is a 74-year-old who presents with his second episode of C. diff in the past 3 months. So initially had a short course of clindamycin for cellulitis, got treated with a 10-day course of vancomycin with complete resolution of his symptoms. But then about 2 weeks after stopping his treatment, his diarrhea has come back full force. He's afebrile, otherwise stable, and able to take PO, and his stool testing is again positive for C. diff toxin. Which of the following do we all think is the most appropriate next step here? Okay, we got some good responses. Okay, so it looks like majority of people are feeling C, which is starting oral FIDAX. Fidaxomicin is something that when I was training was not here yet and has become super popular over the last few years. And the answer for this is, yeah, we're going to start oral Fidax. When this first came out, it was kind of hard to get and super expensive. There is still some cost prohibition for some folks, but oftentimes now the recommendation from IDSA is that oral Fidax is the preferred choice for first recurrences. It also can be the first line choice, so you can do FIDAX from the first time someone has C. diff or oral vanc if the cost is an issue. But really for those first recurrences, it has a better rate of reducing further recurrence compared to oral vancomycin. Again, if there's cost is an issue, we can always do oral vanc. And oftentimes what we would do with a recurrence is consider adding a taper. The only time we would really use metronidazole is in IV form, and it would be in combo with PO-Vanc for severe disease. Now, in this case, you saw this person was otherwise doing fine. They were afebrile. There was no big concerns, and so you wouldn't need IV metro. And then for people who have more than 2 recurrences, next steps, and I again don't know that this will be tested, but just so that we know, are fecal microbiota kind of products. So a traditional FMT, which fecal transplant, or these new suspensions that folks are using, either capsules or rectal suspensions. So just some things to think about. But really the main thing here is in the last few years, this has changed and FIDAX has now become the recommended use of first line and for first recurrence. So next case is about a 66-year-old, comes in with 1 week of fevers, abdominal pain, and diarrhea. He is 6 months post liver transplant for cirrhosis. Had a recent episode of rejection that got treated with high-dose steroids. He is EBV positive, HSV2 positive, and is CMV recipient negative and donor positive. Past medical history, as we know, he had some complications secondary to liver disease, pre-transplant, and recurrent herpes, and is on our typical slew of medications for post-transplant folks. Physical exam is notable for some fever, He has a non-toxic appearance, but has some tenderness, low platelets, low white count, negative CMV PCR, and negative stools so far, including C. diff. Gets a colonoscopy, which shows some inflammation and some ulcerations in the colon with biopsies still pending. What do you think would be the next best step in this scenario? We've got some people thinking. Okay, feels like we have a good amount of answers here. Oh my goodness, I keep scrolling in the incorrect direction. My bad. Okay, so looks like most folks here are thinking A, which is start ganciclovir. Um, and I would say yes, that is what we want you to do. And why is that? So in this situation, the scenario that they're trying to get you to think of is CMV after transplant, right? Buzzwords when we're looking at this or thinking about these types of stems are things with rejection, any mention of high dose steroids, and most importantly, if they tell you donor positive and recipient is negative, right? This means the recipient has never had primary CMV themselves. Um, the disease can really vary in presentation. So we often see some people who have high levels of viremia that are asymptomatic. We see folks coming in with more of a fever, leukopenia kind of episode. But what we often see that is also common is just tissue invasive disease, specifically GI or hepatitis. The tricky thing with these tissue invasive ones is that actually your PCR, your blood PCR might be negative. And so you might get that and be falsely reassured that this person doesn't have CMV because their PCR was negative. Oftentimes, kind of this type of presentation occurs with about the first 6 months post-op when they're really immunosuppressed. Kind of further out, sure, it can occur, but less likely. So that type of 6 months time frame is helpful clue there. With GI disease, the diagnosis is really going to be based on colonoscopy and biopsies. And so sometimes while we wait, we can just start empiric treatment and obviously stop if that is negative. But like I mentioned, the CMV might be negative when it's just GI-based disease. You would, in this situation, start ganciclovir or viganciclovir, remembering that neutropenia, leukopenia are kind of some side effects of those. There are some second-line agents, but you all will likely not be tested on that. So again, take home points here is anytime you see D positive or negative, that should be a little red flag, a little clue, and recognizing that with CMV colitis, you may have a negative serum CMV. Okay, switching gears, we have a 36-year-old who comes in and reports having multiple sex partners in the last year, has receptive anal intercourse with inconsistent condom use. Last sexual contact was about a month ago. They're coming in asking for an HIV test, which is negative. In this situation, what is something you could offer this person to prevent HIV in the future? Looks like we got a nice amount of responses there. So most people are opting for option B, which is emtricitabine and tenofovir, and then a smattering of some other choices. Um, Now, obviously, some of us may do HIV as part of our primary care work. Some of us do not. Even in the ID realm, that is vastly kind of spread out, right? So we're focusing on kind of things that we get asked about as a general practitioner. And so in this situation, one of those topics could be PrEP, and so it's totally testable. And the answer is emtricitabine and tenofovir. So for pre-exposure prophylaxis, this is the recommended kind of combo. So it's a two-drug regimen. So you have TDF and emtricitabine. There is an alternate where you could have tenofovir, alafenamide, and emtricitabine, but this is not usually was not studied in receptive vaginal sex, and so oftentimes the answer is still TDF and emtricitabine. And they may also ask, in what scenarios would this be recommended? And so you should think of folks who are MSM, couples that are serodiscordant, meaning that they have one partner who has a detectable viral load still, folks who inject drugs, and so forth. So other criteria like that. We always document a negative HIV test and a normal creatinine before we use, and we often check for HB status because tenofovir and emtricitabine are both effective against hepatitis B, and so we want to make sure we have all the information before we start folks on this treatment. The other update recently in this area is that we do now have injectables available for PrEP. So cabotegravir has been out for a few years, and so could be testable. I'm not sure if they're going to include that yet, but just wanted you all to know. So if they do talk about an injectable option, or they ask a patient who is not able to take pills in a reliable form, then they may want you to be thinking of these injectables as an option. Now, if we talk a little bit about post-exposure prophylaxis, that's a little different, right? So post-exposure is often used for occupational, but also non-occupational exposures. And we recommend starting it within a 72-hour period. So if they presented someone to you who presented a week later, there's probably little benefit in this. Folks would be treated for 4 weeks, and it's a 3-drug regimen, right? So different from the PrEP, which is only a 2-drug regimen. This is just some information on screening, so I won't spend a lot of time on this. And then just briefly on treatment, again, I don't know that this is going to be a heavy area that's tested because HIV treatment can be super complicated, but just the kind of foundational superficial layer is that treatments usually include 2 NRTIs and integrase inhibitors. And the most common regimens you will see is either Biktarvy, which is the bictegravir, tenofovir, and emtricitabine combo in 1 pill, or Truvada and Tivicay, which is also tenofovir, emtricitabine, plus dolutegravir. So those are usually your first line. Again, I don't think it would be more complicated than that, just for you all to know. And the big thing, really, I said in relation to these cases is thinking about opportunistic infections. So if you're presented someone with pneumonia who has HIV, you might want to consider PJP. If you're coming in with altered mental status, you might want to consider things like toxo and cryptococcus meningitis as options there. If someone is coming in with a really low CD4 count, less than 50, sometimes they want you to think of some disseminated MAC in those situations. So just keeping some of these in mind that could be tested. Okay, so in our next case, we're making good time. Look at that. Okay. Um, Next case here is a 22-year-old who wakes up to find a bat flying around her room. Um, I never would have thought this was a common scenario, but I think I've already heard twice this week of this happening. So I'm like, oh, maybe it's more common than I thought. She denies being bitten, and her parents can't find any evidence of a bite, and the bat flies away. So they weren't able to capture it or bring it in for testing. What is the next best course of action in this scenario? Okay, so it looks like we have a little smattering. Some people who want to start PEP, some people who want to reassure, some folks who want to test for rabies antibody. Okay, I love it. Okay, so rabies, everybody's favorite topic, favorite call. I mean, I don't know if you all get called on rabies. We do. So it's kind of fun sometimes, always stressful. So oftentimes when we think about rabies, we are thinking about bats. And in this situation, this person would probably benefit from immediate PEP. And we could talk a little bit about why this is the reason. So oftentimes we only really need rabies PEP for people who have a bite, who have come in contact with some mucus. And this is just a little chart to use kind of for reference. The exposures really only matter if the mucous membrane you've come in contact with the mucous membrane, right? The issue is bats' bites are pretty tiny, and so it's not always findable if you haven't been watching the bat the whole time. Bats also can lick, right? And licking is not going to leave a mark. So the rule of thumb is if you are in a room or a location with a bat and you cannot keep your eyes on it at all times, i.e., in this example, this person went to sleep, then oftentimes the safer option is to just initiate PEP because you can't really say whether you got bit, whether you got licked if you're asleep. And so that is often my recommendation. Most places have bats that have rabies. I was going to say that there are other areas, depending geographically on where you're located, where there may be rabies in other animals. In Washington state, the only animal known to carry rabies is bats at this time, but again, that's different depending on your location. So this chart kind of walks you through other maybe high risk animals that you want to think about as you're making decisions. So for your reference for later, but oftentimes if there is no, apart from the bat situation where you can't see them circling, if there is no clear bite or broken skin or obvious known contact with mucous membrane, people do not need any PEP. Excuse me. Okay, speaking of animals that can cause diseases, this is my old bunny. He's dead now, but he lived to the ripe old age of 12, which is apparently a lot for a bunny that you get from a random pet store, according to the vet who put him to sleep. What diseases can you get from, not my bunny, but from other rabbits out there? And I don't have a poll for this, so you're just gonna, I guess, oh, you can't shout it out or type it in, huh? Okay, that's fine. I guess I'll just tell you. So what we want to think about is if anyone mentions anything about rabbits is tularemia, which in the past used to be known as rabbit fever. Obviously, other things can cause tularemia, other rodents, rats, but it's a scenario that we like to think about because it can present in a multitude of ways. Often the most common is a skin lesion on your finger or tip of your finger with some glandular inflammation, so some lymphadenopathy and pain. So just a thought there for you all to keep in the back of your head, some tularemia when if they mention rabbits. Okay, our next case here is a 24-year-old woman who comes in with fever and jaundice, some renal failure. About a week ago, she came back from Hawaii after competing in a triathlon. She is tired, she has some scleroicterus, she has some mild abdominal tenderness. Her labs are really notable for this elevated bili and some elevated LFTs as well. Which of the following do you think is the most causative, likely causative agent in this situation? And this would be an example, right, of one of those kind of first order questions for a organism that might be less common or you don't see as often. And so really the answer is just what is this? Mhm. Nice spread. Okay, so looks like there's a couple of options here. Some people liking virus, some spread out gram positive, gram negatives, because really they can do anything. Majority of people here thinking that this is a spirochete. Okay, so let's talk about this a little bit. The answer here that we're trying to think about is indeed a spirochete, but which spirochete are we talking about? And hopefully what you all had in mind was leptospirosis. So this beautiful squiggly little thing that you see. Um, Leptospirosis is one of those diseases that we often only get tested on in these stems that kind of have all these clues, right? So it's found in fresh water and can be transmitted from water most often, but also soil or animal tissue, which is less likely to get tested because it's contaminated with rodent urine. So if you see a stem talking about freshwater exposure in tropical places like Hawaii or South Asia, if they mention floods, that's another common one. Often on physical exam, which you'll look for is a conjunctival suffusion. They may mention that straight up, or they may just describe it. And really looking for those elevated LFTs and a bilirubin that's kind of out of proportion comparative to those. And so that's what you want to keep in mind if you hear those things. They're trying to get you to get leptospirosis. Almost every stem I've seen has mentioned a triathlon. So I feel like with time, they're going to start changing those over, but that's just kind of the idea there, something to keep in mind. And if you get a picture, which I don't think they'll do to you, but if you do, now you know what it looks like, a little squiggly little thing. Okay. Moving on to another case. So we have a 45-year-old who presents with a pustular rash on his lower extremities. Afebrile doesn't really have any other complaints. Mentions recently he started a new relationship, and so they were spending the weekend up in Lake Chelan, where they hiked and they had some time in the hot tub. He has a superficial swab of his skin, which shows some MSSA and then a ton of Pseudomonas. Which of the following is the best treatment option? And again, now this is an example of a question with common bacteria, but kind of asking a second order question, which is like, what treatment would you do in this process? Okay, we're still thinking. It's good. I like when this takes time because it means we have to work our way through it a little bit, which probably means it's good. When you guys get 100%, I'm like, oh, I need to throw this question away because everybody knows the answer. Okay. So it looks like a nice spread here between Cipro and no antibiotics and a smattering of some other things. Okay, I love it. This question I like because when we're thinking about ID and we're asked about treatment, our knee gut reaction or knee jerk reaction, right? Yeah, knee jerk reaction, that's the correct phrasing, is always we have to treat it, right? Like it must need treatment. It's an infection. And the answer here is actually no. This situation, or at least this stem, is talking specifically about a phenomenon known as hot tub folliculitis. And this often comes from exposure to underchlorinated hot tubs. So you'd get this kind of smattering. And again, this could be in the legs, on the back, on the stomach, really any skin exposed area. And you get the superficial infection that is often due to Pseudomonas, though sometimes it can be MSSA or MRSA. And you actually don't need to treat this with anything. It will go away on its own. Now, if someone was to develop like an abscess that looked a little bit deeper, or maybe like a full cellulitis surrounding all these lesions, then yes, maybe you could consider treatment. But for the folliculitis itself, actually, you don't need to do anything, and this will clear up. This I always think about this every time I get into a hot tub, which is unfortunate because that's how my ID mind works. Is like, what am I being exposed to right now, and what disease could it cause? But oftentimes, this is not super common, but something that could definitely happen. Okay, so now we have a 50-year-old who is coming in with compensated cirrhosis, secondary to alcohol use, and he goes out to eat with his family at a restaurant. About 8 hours later, he develops some altered mental status. He has some hypotension that seems to be getting worse, has a fever, and he has this kind of bullous rash all over. What do you think he ate that caused this presentation? I hate these food questions because, like I just mentioned, every time I do anything, I think about the IT implications. And I love food, lots of different food. And every time I go, I'm like, huh, what could I possibly get from eating this? And is it worth the risk? The answer is always yes, it's worth the risk. But, just I understand making people paranoid with these types of questions. Okay. Seems like people have settled into their choice. All right. It looks like most of you are trying to blame those oysters. Now, oysters can get blamed for a lot of things. Let's see, is this something that we would blame these oysters for? And the answer is yes. Why do we think that this is the cause? And what do we think they're trying to get you to guess, right? It's hard to know what food it is if you're not thinking about what is the organism they're trying to get you to guess. And in this situation, when you see words like cirrhosis or hemochromatosis, bullae, what they want you to think about is Vibrio vulnificus. So Vibrio, similar to the imagery that you see on the slide, actually is a gram-negative curve-shaped rod. And it likes to hang out in the water where oysters tend to feed, which is why there's an association with oysters. Vibrio can cause pretty significant sepsis in people with underlying risk factors, which includes alcohol use and liver disease. and anyone with like excess iron. And the reason is that Vibrio thrives on iron. It requires it to grow and to proliferate. So if you see someone with hemochromatosis, that's also an underlying stem. People with liver disease may have iron metabolism issues. And so it just gives it kind of a ripe environment to grow. Has one of the highest mortalities of foodborne illnesses. Luckily, it's not super common. And oftentimes this will just grow in blood cultures. It's just a gram negative, so doesn't need anything special, and will show up. But if you see someone coming in with this kind of septic bullous rash picture, we want to think about Vibrio. The other way that this presents, other than foodborne, is through wound infection. So if someone has a cut foot and they're out in salt or brackish water and they come in with a significant wound infection that's looking black and gangrenous and gross, Vibrio is something you want to think about in those situations as well. So main driving point here, oysters, rash, sepsis, think about Vibrio. So this next case is a 22-year-old who undergoes high-dose induction chemo for AML. They're treated empirically with Ceftaz and Banco for febrile neutropenia, as we often see in these folks, but their cultures remain negative. 3 weeks into this course, while they're still on antibiotics, he gets a fever, a cough, and pleuritic chest pain. So a chest CT is obtained. Give you a second to look at this chest CT. Okay. Based on these findings on this imaging, what do we think the best empiric therapy would be? Okay. So I love the spread. What I love most is that nobody picked meropenem. So nice work, everybody. Not that there's anything wrong with meropenem, but I'm picky about when we can use it. Okay, so it looks like there is a really nice break here, even split between amphotericin and voriconazole. So let's talk about that. Um, so fluke, amphotericin, vori, all great for our antifungals, and it sounds like people here are thinking that there might be a fungal process that they're interested in looking at. If we go back to the CT, what really should draw our most attention is this sign or this little picture right here with a little area. And what we like to talk about in these situations is something new. Oops, I forgot to tell you the answer. The answer is voriconazole, but I'll tell you why in a second. And so what we like to look at there is when they're showing you that type of imaging on CT, what it's called is a crescent sign, an air crescent sign, or a halo. They may just put that in the stem if there's no imaging, but that's what they're trying to get you to think of. And anytime we think of that word, what we're trying to get at is no, okay, I was gonna sneeze, but apparently not. What we want to think about is aspergillus, especially in folks with prolonged neutropenia, right? They are ripe for developing kind of this acute aspergillus picture. There's a spectrum of disease, which you don't need to know for aspergillus, but just so that you're aware, there's invasive and there's non-invasive. Um, and in these scenarios with these patients, what we often do is we will see these findings on CT, and we would initiate treatment. Vori is the first line therapy for aspergillus. Now, if you were unsure and say the findings on CT weren't as clear and you were worried about other fungal things like mucor, or rhizopus, things like that, then you may opt to use that amphotericin upfront. But in this case, it's pretty typical presentation with the findings and after a few weeks being neutropenic from the beginning, that you probably feel comfortable enough just treating for aspergillus with the voriconazole alone. In these scenarios, you can get a serum galactomannan, which can be helpful if it's positive, but it has a poor negative predictive value, so not always, the best thing to use if you're super uncertain. Definitively, you could do histopath or biopsy if you're able to in these folks if they have areas that are easy enough to reach. And most often, what we do in these cases is we will treat empirically in these situations because it's probably aspergillus. There are other options other than Vori. So if folks have any side effects, which often we think about neurotoxicity, visual hallucinations. These are issues that can pop up with 4A. You can do other things, but it is the first line option. So main point here being that if you see a halo or air crescent sign in a patient with prolonged neutropenia, you want to think about invasive aspergillus and start 4A console. And the best thing about starting things empirically is that you can always stop them. So, nothing to worry about too much. So our next case here is about a 34-year-old, otherwise healthy, coming in for fever, myalgias, and some diarrhea. About 4 days ago, she had surgery and she got these saline breast implants bilaterally. On exam, she's febrile to 40, which is pretty high. She has some low blood pressure. She has a heart rate of 120. Overall, looks pretty sick. She also has a notable blanching erythematous rash kind of throughout. Her surgical incision, though, does look good otherwise. She has a mildly elevated white count, some low platelets, an elevated creatinine, negative pregnancy test, gets a ton of cultures, gets fluids, all started on empiric antibiotics, and she's sent to the ICU. After these basic kind of steps of resuscitation, what is the most appropriate next step? People are still thinking. Okay. Okay. So looks like a lot of people are opting for surgical consultation, but some thoughts about antibody testing or a vaginal ultrasound as well. Great. Okay. So in this situation, our next likely step is going to be a surgical consultation for those breast implants. So let's talk a little bit about why. So what this stem is trying to get at is a form of toxic shock syndrome, specifically staph. The typical teaching is in folks who are menstruating, and it's associated with these absorbent tampons being left in. And that's classically how we've kind of thought about this picture. But there is non-menstrual related forms of staph toxic shock. And those are usually associated with procedures, either cutaneous infections, even people being postpartum, or post-abortion as well, are times that this would pop up. But the surgical procedures kind of gets us because it's a different area, right? So if we thought this was related to pregnancy or menstruation, then I think vaginal ultrasound obviously makes sense here. But in this person who that wasn't really where the stem was leading, but she did have recent surgery, the thought is this probably is related to the surgical procedure. Now, the interesting thing about this is that the surgical site often doesn't show any signs of infection, and that's because this disease is toxin mediated, so there may not be a lot of inflammation. So we wouldn't notice anything on the outside. But we should definitely think about getting those implants checked out because that's the most recent thing and is likely the cause of what's going on here. We often see rash and fever, obviously shock as well, because that's what it's called, staph toxic shock. And you may have other associated symptoms, though not always present. Staph toxic shock, we'll talk about strep in a little bit because we hear about that a lot. But really diagnosis for this, you'll have maybe blood cultures, but they're often actually negative compared to group A, toxic shock, when those blood cultures are actually tend to be more positive. We would treat this with something to kind of inhibit that toxin release, so clindamycin plus some MRSA coverage. And really, the surgical consultation is the key here in these situations. And these little monsters up here are grape clusters because that's what your staph is going to look like on stain. So thinking about septic shock, rash with recent surgery, and negative blood cultures, or an okay looking wound, we want to consider staph toxic shock. The other one that we hear a lot about is strep toxic shock, and actually this one has a much higher mortality than staph, which is interesting because we always think of staph as our more lethal bug. This can also be post-surgical, but oftentimes we see this in the form of an NSTI. And so unlike staph, well, like I said, when we don't actually find any clinical skin findings, it's more inside. This one, we do sometimes see necrosis and breakdown, and those are surgical emergencies as well. Majority of these folks will be bacteremic, unlike staph, as mentioned, and they don't usually have a full body rash. And then there's are your strep, which show up in your little chains. Okay, this is my dog, Noodles. And you already met my rabbit who passed away. This dog is alive. He's 3. And since we're talking about things that can present with a shock-like picture, can we think of a bacteria that we would see associated with dogs? And I know that I can't see you write anything, so I'm going to tell you, but I want you to think about it for a little bit too. But one of the things that can also present with this kind of fulminant shock picture is capnocytophaga, which is often found in dog bites. So if you got bit by a dog, you present kind of with this really profound shock from something that's just like a little bite. You want to think about capnocytophaga. We often use unison for this empirically as well as debridement to kind of help us get past. So they are cute, but they can also be deadly, as I mentioned, most things in this world in relation to ID. Okay, so next case, we have a 32-year-old who presents to the ER in December, coming in with about a day worth of fever, chills, and myalgias. Not taking any medications. Past medical history is just notable for a splenectomy after a motor vehicle accident a year ago. Comes in with a temperature of 38.4, a little bit of tachycardia, blood pressure's okay. Rest of exam is kind of unremarkable. It's a maybe very mild white count elevation. Otherwise, labs are looking okay. UA is negative, chest x-ray is negative, and blood cultures are drawn. So in this gentleman who has a little bit of a fever, otherwise young and healthy, what do you think is the next best step in management? It looks like we have some people still thinking. Take your best guess. Okay. So looks like here people are thinking about admitting this person and getting them some ceftriaxone, but also some folks thinking about admitting to the hospital, getting some vaccinations perhaps, and maybe sending home to return. Um, and in this scenario, I would also, think about a young person, otherwise healthy, has a fever, nothing really sticking out, numbers don't look terrible. Maybe it is okay to send this person home and have them come back with return precautions. And often I would say this is probably the right answer, except in this one scenario, which the right answer is to admit and give some ceftriaxone. And that's because this person does not have a spleen, right? So in our folks, whether they have a traumatic splenectomy or so other reasons not to have a spleen or just functional asplenia, the risk of sepsis has a pretty high mortality in these folks, whether they're young or otherwise healthy. And they need pretty prompt antibiotics and to kind of be monitored. The common organisms we think about are what we say are, encapsulated organisms. So our pneumococcus, meningococcus, or H flu. The Capnocytopica, which we kind of just talked about, and then Babesia, which is a little bit rarer, but can also present. And so really the thing to keep in mind is if someone is coming in with any signs of early infection, we really should be monitoring them if they are postsplenic or asplenic, because they're not really going to be able to kind of, deal with things the way that other folks would. If they are trying to have you think about babesia, some things that they might include are something in the Northeast, a recent blood transfusion, hemolysis, something like that. But really, it's location based for babesia. And then with capnocytophaga, we just talked about this, but things like dogs, history of alcohol use, purpura, things like that would be a way for them to get you to guess those. The other ones that are on here, they probably don't need much more buzzy words for you to think about. Okay. So our next case here is a 62-year-old, otherwise healthy, admitted to the hospital with fever, weight loss, and this new onset dyspnea. The exam reveals some stigmata of endocarditis, so some chain-way lesions, some Osler nodes, and TTE shows an aortic valve vegetation. Um, the blood cultures are currently going Strep galliticus, also formerly known as Strep bovis. I should say a lot of things get renamed for fun. Not fun for me, not fun for you. I guess fun for the people who do these namings. But oftentimes when you're being tested on them, they will give you the former name if it's relatively new so that folks know what's kind of going on. So just a mention there on the side. So in this person who has Strep galliticus, what additional workup should be done? And then here you see, again, another example of those second order questions where the bacteria is probably common, but what would you do otherwise? Okay, majority of you here are thinking about a colonoscopy, which is great because that means the teaching has been continuing and we're now recognizing this as a need. So yes, in this situation, if someone has Strep galliticus grow, we always think of a colonoscopy, and that's because of the association with Strep bovis galliticus and colon cancer. So often, more often than we probably think, about 10 to 25% of people who present with this type of bacteremia end up having an underlying colon cancer. And so we always recommend colonoscopy. And actually, even anecdotally in practice, I have seen this actually quite often recommending a colonoscopy for these people and then them having colon cancer. Other things that we can see is endocarditis and meningitis, but again, less often. There are other, so this has been studied and there's a couple of other things, but really the only other organism that we still recommend a colonoscopy with, other than Strep galliticus, is Clostridium septicum, which is also similar to this in that there's a high likelihood that someone has underlying colon cancer if they have blood cultures. I would say Clostridium septicum is a rarer thing for me to see, but I do see Strep galliticus quite often. So the point here is that any person with Strep galliticus or Clostridium septicum bacteremia needs a colonoscopy to rule out colon cancer. Very testable and something that you all already clearly are aware of. So the Clostridium septicum is another option that they may flip for that. So just wanted to make sure we mentioned that here today too. Okay, case 13. We have a 60-year-old who presents with some progressive shortness of breath and fevers for about 2 weeks. Has a history of diabetes, lives in Arizona, comes in, exam is notable for some tachycardia, some bilateral crackles, no wheezing, a little bit of a white count, and some notable eosinophilia. And the chest x-ray is just notable for some infiltrates bilaterally. Which one of these organisms do you think is the most likely etiology? Looks like we have a couple of folks still thinking. Okay. All right. So looks like most people here are thinking Coccidioides immitis. Okay, and let's talk a little bit about that. So yes, the correct answer here is in someone presenting from somewhere like Arizona with pulmonary infiltrates, probably the most likely answer is going to be cocci. So this is an endemic mycosis similar to our blasto, our histo, our cryptococcus. These are things that are in our environment, though depend on the region that you're in. Oftentimes we will see infiltrates, pulmonary infiltrates in these folks with eosinophilia. But a lot of people who are residents of these endemic areas will have positive cocci with no symptoms. And oftentimes, people who do even get sick, it's really time limited and kind of improves on its own, so we don't need to do much. But there is a small subset of folks who will present to the hospital with pretty profound pneumonia and illness overall. And for those folks, they come in with the fever, the coughs, you might hear it called valley fever. And those people we will often treat. There are some extrapulmonary manifestations of cocci, so you can technically get osteomeningitis. And the osteo can go anywhere. I've seen folks with sternal osteo, it really just depends. And again, those people obviously would have a much longer treatment course. Important here is epi, right? So again, this is more of a Southwest disease. So Texas, California, all these other states on this map that you guys can probably name and don't need me to name for you. But I will mention that due to a lot of changes in our climate over the last few years, that some of these things have spread out a little bit. And so with time, these may not be as regionally limited as we once thought. So even in our little area of Washington, Portland, these things have become more common when they weren't before. So just something to keep in mind for these diseases as climate changes, so does the location of some of these endemic mycoses. Other ones that we talk about with this little map I just wanted to show you is we have histo, blasto, and cryptococcus. Cryptococcus is up here in the gray, so we have some cryptococcus in Washington, California. And then we really think of as histo in our Midwest Ohio Valley regions, and then you have some blastomycosis kind of spread out in the pretty green. So just something to think about. A lot of times these diseases are location-based. A lot of these stems will include locations, and if they do, they're probably trying to get you to think of something. Okay, great. So we got through the cases. I have some additional pearls for you all that we may not get through all of them, but they are there for your reference, but I will walk you through some of these since we have time. Because I talked about my rabbit and my dog, I had to mention my cat because she would be upset. This is Iris. She's pretty. She's nice most of the time, but she's a cat. So cats have a lot of diseases and they can be in a lot of stems. So I just wanted to walk through some of these stems that you might see. So if you were to see a cat that poops and they mention cat poop, what they want you to probably think about is toxo. Okay. And I would have opened this up for you guys to tell me, but I'm gonna just go through them for a more efficient use. Okay, if someone tells you about a kitten and they scratch them, this should have you thinking about Bartonella. Okay, so cat scratch fever, disease, whatever you want to call it. If you have a cat that bites you and then this cat suddenly dies, it most likely has rabies. Okay. Often we don't see a lot of cats with rabies, but totally possible. So a cat that bites you and then dies has rabies. If you see a cat that's pregnant and having children, they're probably trying to get you to guess Coxiella. Coxiella is technically, I guess, zoonotic, can be acquired if a cat is pregnant or if an animal has a stillbirth and you are present for that. The stillbirth is caused by the animal being infected by Coxiella, and so that is a way for you to get Coxiella, and it can present in a variety of ways. So if they tell you anything about a cat that recently had a stillbirth or an animal that had a stillbirth, they're trying to get you to think of Coxiella. If you have a cat that's just kind of dead and you don't know why, that cat probably had tularemia. And finally, if you have a cat that is coughing and looks sick and you just want to help it, don't, because it probably has the plague. And there has been a couple of cases of the plague in Colorado, and some that we've seen over here. And this is actually the scenario that there was a sick cat, someone took it, and then they got really sick. And it was because of Yersinia. So just some things to think about. Cats are cute and cuddly, also carry a lot of potential for diseases, but most of the time it's totally fine. And then some other things I want to talk about that could be testable here is just some little endocarditis pearls. So endocarditis is something obviously we see often. When they're testing it, they may be asking about things like what do we use to further diagnose if we can't see it, indications for surgery, so forth and so on. So obviously endocarditis is diagnosed with blood cultures. You get a TTE in these folks or a TEE. and they may have prosthetic valves. If they have a prosthetic valve, most often they want you just to get a TEE because you're not going to be able to see things as clearly. Early surgical indications is significant heart failure, if it's fungal, if there's significant heart block or large vegetations. Again, this is not always the same in clinical settings, just something for you all to think about. And then what is often tested is this idea of dental prophylaxis, right? So for anyone who has a history of endocarditis, uh, or someone who has a prosthetic valve, unrepaired congenital heart disease. So heart disease that is repaired in early childhood does not meet this criteria, but anything unrepaired or repaired in the last 6 months would meet criteria for dental prophylaxis. Okay, so just something to think about there. So you need two things when we're thinking about dental prophylaxis. You need the right history, right, and the right risk factors, as well as the right type of procedure. So folks need it if they are doing dental procedures or anything else that's going to interrupt that mucosal barrier. And oftentimes amoxicillin is the go-to prophylaxis in these situations. Now, hopefully this doesn't show up on your boards, but I think one of the hardest questions that people can ask about endocarditis is it endocarditis or is it lasagna? Now, I have not seen this tested, though I think it is totally up for grabs if necessary. So just a little practice for you all here. I'm not right before lunch, so I didn't feel as bad for putting this up. But, maybe just test yourselves a little bit so that you're prepared for any scenario possible. And then just some other things that you will see on here that are available. So some SSTI pearls. I know you all are probably pretty comfortable with these things, but just things to think about if they come up. A little summary for you. CNS infections are an area that can totally be tested. Oftentimes, they ask about empiric treatment for things like brain abscesses, which is going to cover a type of all the things that could happen in the brain. So ceftriaxone and metro. And then typical coverage for bacterial meningitis, oftentimes they will add maybe a special category. So for example, someone who is over the age of 50, they may want you to think about listeria, or the answer may be listeria, and so you want to add some ampicillin. And then if somebody was coming in who was older, had a history of HSV, they might want you to think about some HSV encephalitis, so you might want to be adding some acyclovir there. URI stuff, they probably won't ask you too much, but just some things in case it does pop up. And then for lower tract infections, some common things is like the therapy for our CAP treatment and diagnostic things. So keeping in mind atypical infections, which I'll talk about in this next slide, is just a little way to kind of think about, again, those first order questions that might be not common organisms, but they want you to think about or guess. So some pneumonia associations that they may get at is if they ever say anything about birds, they want you to think of Chlamydia pistachii. Horses is rhodococcus. Tularemia we talked about a little bit, but rabbits, obviously, and pneumonia, that's what they're trying to get you to get. If they talk anything about cabins or rat poop, hantavirus is a good answer for that. And then we talked about farm animals or anything giving birth. Coxiella can present in a pneumonia picture. And then obviously Legionella, which I think we are more comfortable with thinking about in any air conditioning, fountains, anything that's really aerosolizing that water. What else is on here? Some viral hepatitis. I'm not going to go through these because I have like 2 minutes, but just showing you what's here. Some osteomyelitis stuff, which again, harder to test, but they could be talking about whether how you would diagnose it or what you would do going forward. So, and then this I think is helpful because as I mentioned, every time we think about infection, we think about things that need to be treated. These are some infections that do not require any antibiotics. So if we are asked anything about positive urine cultures, but it's a person who has no symptoms, or yeast in a urine culture, we do not treat those. So something to remember there, asymptomatic bacteria. The only time, if they include it in testing, that we would treat asymptomatic bacteria is someone who is going to get some type of urological procedure and anyone who is pregnant. So those are the exceptions to this rule. So pregnant folks, anyone getting urological procedures, you would treat their asymptomatic bacteria. We talked about hot tub folliculitis not needing any treatment. Most URIs do not. Bronchitis, probably not. Sinusitis that is present for less than 10 days is probably viral, not bacterial, so it doesn't require antibiotics. And in general, if things are stable, viral, sound like they could be allergic, they likely don't need anything. And then you have your little answer key, and that is all I have for you. Thank you. And I finished just on time. But again, I know I went fast through those last slides, so please go back and take a look and get additional information from them as you need them.
Thank you. That was fantastic.
Thank you
Adorable
for
pet
having
videos
me.
are always appreciated.
I know. Somehow I feel like their animals are watching me, and so that I have to mention them.
Oh,
Thank you all. If you have any questions or things that you want to see in future talks that you think might be helpful, please let me know or let whoever know. You all have my email somewhere. Love to get any feedback.
thank you, Dr. Hussein.